first of all, you guys have, what, 14 surgeons that are doing total joints? And it's a standardization of that that's important that we'll kind of articulate as we go through this discussion. But one of the things that's, I think, is really unusual is the anterior hip aspect. Dr. Wong, you want to talk about that and kind of maybe how that evolved? Because that's quite unusual. I've looked around the Bay Area, and there's a couple of guys doing anterior hips in the Bay Area, but they're affiliated with hospitals, and there's not a group like you guys that are even in the whole Bay Area that's this precise and that committed to doing anterior total hips.
We're lucky, when I joined the group 6 years ago, it was easy for me to decide to just, join this group because Dr. Toma has already had everything set out, and he kind of pioneered the program locally already, both at the hospital and the surgery centers. It's easy for us to all get on board because all the motion's already set in place and the equipment's there, the staff's well trained, and I'm obviously biased. I think that patients do better. At least in the ASC setting, it's perfect. Helps with standardization too, and getting the team to do the same thing every time. And
how about knees? Does that exist for knees too? Is that the same for the total knees? Is it pretty standardized towards one implant and one fairly common technique?
We're all using the same thing, so we try to standardize our trays and our implants and the way that we, I guess we'll talk more about that, but the pre-op protocol, which Dr. Peters had a big part in doing. So from a facility perspective, we touched on this a little bit earlier, but implants. So that's a big cost. How much have you been able to bring down your cost by standardizing your implants in this process, and your facility storage and how it impacts that if you're storing, less product?
Implant is one thing and trays is another. And Wendy is our total joint medical director for the program, has really been involved in helping us standardize the trays around the specific vendor and the implant. And then that training ultimately helps with all of the staff so they know what to look for. So it is a collaborative effort with everybody, but I think now that we are, really capitalizing on the total joint replacement program with the knee, everybody knows what to look for. We've gotten it down to, I think, about 2 trays for our total knees with the help of Wendy, and I think it's just going to get better.
So when Dr. Toma or Dr. Wong is doing a total knee, the process is going to be very similar. Trays will be similar, the implants are similar, so it just makes it easier, less stress on the staff, and a lot more predictable on your cost.
As I started as the director, actually took time to lay out all the surgical steps. I think from a surgeon's perspective, that's something that, if you dedicate the time and it's in a nice binder, not sure anyone reads it, but it's a reference right there for them to look back on. There are a lot of things that I think you don't need, but you just want to have just in case as a surgeon. But as you get more comfortable, again, operating in an ASC environment, you understand that this is not the hospital. You don't really need like 5 retractors for one job.
Yeah. Is that you that has that discussion with the surgeons, or is that Shay or Dr. Peters?
I think it helps coming from a colleague.
So there was a story you guys were talking about earlier where you were standardizing a preoperative drug, postoperative drug. Talk about that, because that was something that really brought down the cost.
Just standardizing as we got busy, our volume grew, and then everyone was doing different things, for their multimodal pain regimen. Finally, it got to a point where, since our volume was growing so much, that I was like, well, why don't we just try to do what the literature says, right? So the multimodal regimen, which is clearly established in the orthopedic literature for total joints, especially outpatient total joints. So we just had to get all the surgeons to show up to a meeting and say, hey, you know what, this is what the evidence are suggesting, and so are you guys okay at least doing it at Sequoia? In the hospital, I think things are a little bit harder because you have patients with chronic pain and stuff like that. And so since this is kind of a more finely selected patient population, and if you show surgeon data and evidence, I think most of them are willing to make a change.
And you got them all on board?
Yes, now we all do the same thing.
Yes, they did.
Got a nice chart, everybody gets the same regimen in PACU, they get the same regimen at home, they get all their medications beforehand. So it's nice. So
every aspect that you're able to standardize brings down cost and helps you to, the throughput. It's just easier, it's easier on staff, and it's easier to pull for cases and that sort of thing, correct?
Everything, including emptying your bladder just before you go to surgery. That was part of it.
Every aspect of it, yeah.
And it improves quality, right, which is the ultimate goal.